Our next talk is going to be Dr. Kori Hudson, who's a professor of clinical emergency medicine at Georgetown University School of Medicine and practices sports medicine and emergency medicine with MedStar Health in Washington, D.C. and Northern Virginia. She received her undergraduate medical degrees from the University of Virginia and stayed at UVA for residency before completing a fellowship in primary care sports medicine at MedStar Washington Hospital Center. She's been on faculty at Georgetown since 2006 and is the team physician for the Georgetown University Athletics, the Washington Wizards, and the Washington Mystics, and is a consulting physician for the Washington Capitals and the Maryland Jockey Club, where she serves as their EMS medical director. She's also served on the Big East Conference Health and Safety Committee, the NCAA Division I Concussion Safety and Protocol Committee, and is currently on the NHL Emergency Action Planning Committee, the NBA Emergency Preparedness Committee, and the World Athletics Expert Advisory Board. As a former paramedic and certified athletic trainer, she enjoys working as a part of the sports medicine team and enjoys the multidisciplinary approach to athlete care. Dr. Hudson, would you like to share your screen?
Sure. I feel like that was a whole lot of words to basically a whole bunch of people that I feel like I know. So let me see if I can get in here. I often say, many of you have heard me say, the emergency medicine, sports medicine community is a small one. We are all good friends here. We all know each other well. And as Ben mentioned earlier, when you get to know this group, you know you can drop a text, you can send an email, you can easily pick up the phone and call any of us, and we're always willing to chat. Many of you have taken those kind of calls from me. So we're going to talk about what's in my bag and what makes emergency physicians particularly good for the sideline. And let's kind of dive right in here. I have no relevant financial disclosures to this talk. We're going to talk about how we prepare for the scenarios we see on the sideline, how we really understand and modify that for the environment we're in. I'd like to talk a little bit about like literally packing your bag and how we plan for success and prepare and practice your plans. Ooh, all of a sudden my slides aren't advancing. All right, there we go. All right, so I think when we think about covering sidelines, and many of you have done this already, many of you aspire to do this, I think we start by thinking about the common injuries we're going to see. And the common stuff we see every day or very frequently are things like musculoskeletal injuries, lacerations, epistaxis, concussion. And I'll tell you that the management of these things on the sideline is really not significantly different than the way we would manage these in the emergency department. Again, we don't always have all of our tools and toys. We don't have our nurses ready. We don't have our Pyxis. But managing epistaxis is managing epistaxis. You just got to have the right supplies and you'll do just fine. Musculoskeletal injuries, the biggest question we have on the sideline is when to image and how, and then kind of making some of those clinical decisions in real time. But I think where emergency physicians really shine on this sideline is the management of critical injuries. So when we think about the risk of cervical spine injuries in particular, we think about the management of sudden cardiac arrest, anaphylaxis, heat illness. This is where our critical thinking skills, our ability to recognize sick versus not sick, and our ability to lead a care team really shines through. And so when thinking about how to prepare for sideline medicine, I think we really play to these strengths as emergency physicians. I'll tell you, I started my sports medicine career a little bit backwards. Many of you know this, that I was an athletic trainer before I went to medical school. I came out and trained in emergency medicine, and I actually practiced as an EM attending for 7 years before I went back to do a fellowship. And during that 7 years, I filled in as the team physician at Georgetown when they were between primary care sports physicians and looking to hire. And they'd never had an emergency physician on their sidelines before. And when we made our next hire of our new head team physician, they asked me to stick around because they said, wow, we've just never had anybody on the sideline who could make decisions so quickly and definitively as you do. We really like that emergency medicine mindset. And then from there, we ended up starting our own fellowship at Georgetown, and the rest is kind of history. So we're bringing people over to this belief that emergency physicians are really great in this role. So when we think about the type of high-risk scenarios we're preparing for, and these are the things that percolate in the back of my brain when I'm on the sidelines, it's everything from that severe orthopedic injury to heat stroke, cardiac arrest, thinking about sickle cell crisis or ECAST. Overdoses are becoming, unfortunately, more common in the general population and in our athletic population. Mental health emergencies, respiratory emergencies like severe asthma. And then we can think about things that are venue specific, like severe weather events, or even mass casualty incidents like we saw at the Boston Marathon bombing many years ago. And again, I posit that emergency physicians are really the ones you want next to you when any of these things happen. Understanding the environment really depends on where you are, right? When I'm with a professional sports team, I'll give the NBA as an example. The NBA has about 6 staff per player, right? Like the player to staff ratio is ridiculous when you think about athletic trainers, physical therapists, strength and conditioning coach, exercise physiologist, performance specialist. And then we get into the coaches, right? I was just talking about the health and safety team. That means that when there's an emergency on the sideline of an NBA game, we have all the help we possibly need. The NHL has been well documented. There are about 28 physicians and other health providers who are on the sidelines of an NFL game. So when an emergency happens, you're well covered. Colleges will vary widely, right? That could be a Power Five conference team, right? Like your University of Alabama on the sideline of a football game, you're going to have resources that rival the NFL. If you're at a small Division II or Division III school, as a fellow, you may be there by yourself on the sideline with an athletic trainer, and then you got to help call in for help when you need it. High schools again vary, right? In our really urban area here in DC, we have some high schools that have a lot of coverage. Certain areas are now starting to require physicians on the sideline in addition to athletic trainers. Many high schools, again, you may have a parent who's on the sideline, who's the dermatologist or the podiatrist or something, who's volunteering their time as team physician, but is truly not really trained in primary care sports. Youth sports, I often think about what I see when I'm at my kids' games. And honestly, some of the worst illnesses and injuries I've seen have been at my kids' games. And I have to ask, when I'm at my kids' games, am I there as a parent? Am I there as a doctor? Or do I really want to be prepared to be both? When we think about road races, right, we need to think about the size of the race, the scope of the race, the distance of the race, and the number of providers we need along that course and what our role is going to be will really depend on all of those factors, right? The Chicago Marathon, the New York Marathon, 50,000 runners has a whole lot more team physicians, has a whole lot more primary care sports and emergency physicians than your neighborhood 5K. And then I throw out there extreme sports because I think as emergency clinicians, we kind of gravitate towards some of the extreme sports, both as athletes and to cover. And I think extreme sports are great when we think about things like adventure racing, when we think about things like some of the X Games type sports. My challenge there and that I give you is that a lot of these happen far from the urban center. They're happening further away from that hospital, from that trauma center. And as the emergency clinician who agrees to cover those events, you need to think about, again, what resources do you need to bring when you're going to be far away from a hospital, far away from transport? Then again, you want to think about who's on the sideline with you, right? You may be there as the emergency physician. You may have other physicians there with you. You may have radiology resources nearby. Again, in the NFL, I've got massage therapists, so we've got athletic trainers, we've got chiropractors, podiatrists. But if you're the fellow covering a high school game, it may be you and an athletic trainer, and you may have a nurse practitioner who comes out of the stands, right? Who says, "Can I help?" And you're going to have to make that decision of do you say yes or do you say no? Our inclination is usually to say, oh, no, 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 right? We're on the sidelines. We've got this. But we had a case a couple years ago in our area where one of our MedStar Maryland Combined Fellowship fellows was on the sideline at a lacrosse game when a young man had a commotio cordis event. And coming right out of the stands was a nurse practitioner from the cardiovascular ICU, right? Like if any better person could come out of the sidelines at that moment, I don't know who it is, right? Like that's who you want, but you need to know when to say yes, thank you, and when to say, no, I think we've got this. And again, that may depend on the severity of the event you're managing, and it may depend on who's turning up to help. I think it's important when we talk about our role on the sidelines to make sure we stay in our lane a bit. And this has a lot to do with how we interface with the other healthcare providers there, in particular with our athletic training colleagues. I think there is a temptation when we're early in our career to kind of hip check that athletic trainer out of the sideline to get down beside the athlete and do that Lockman's test or do whatever we think is the next best thing to do. But I want to remind everybody that in general, our athletic trainers know the athletes better than we do. They know who tends to be dramatic. They know who's going to say few words. The athletes know them. They trust them. They also know that when doc shows up, like something's bad wrong, right? So if I'm out there in the middle of the floor, they know that things may be worse even than they thought. That may lead them to have more anxiety or more panic. So my temptation usually is to let the athletic trainer go out first. If they're slow, right, nothing's happening, I kind of get out of my seat or I walk a little closer. I make sure I'm within sight line so that athletic trainer can see me. Either they're going to put up the emergency symbol, which for most of our places is the fist over the head, or again, at the college level, at the high school level, if they're just really taking their time, we'll usually walk out and just kind of stand behind them a little bit and listen to what's going on, right? And try to figure out how can we help? Do they need our help? Do they want our help? Again, if the emergency sign goes up, or in many cases, we've got an agreement that if they get down and hold C-spine manual traction, that's the same as a fist in the air. We're going to come out to them. Then we're going to come out. And we want to talk a bit before that emergency about what that role is going to be, right? Is the person holding C-spine going to be in charge of this case? Or do I become in charge of this case when I get out there? When there's a cardiac arrest, I argue it should probably be us, but you want to have that conversation before the event because many paramedics are used to taking control of that cardiac arrest. And when they're coming to the scene at the same time, do they know that we are emergency clinicians and not the orthopedist? Nothing against our orthopedic colleagues, but when it comes to having an orthopedist run the code or have the paramedic run the code, I'll generally pick the paramedic, right? But if I'm there with a paramedic, we want to work synergistically, right? We don't want to have a power struggle at the side of the athlete. And then it comes to packing your bag. And I think that early in our careers, we tend to do this, right? We tend to load ourselves down with extra stuff and all the goodies, and we want to take our handheld ultrasound and we want to take an intubation kit. And I've heard people come ask me, do you carry an RSI kit when you're on the sidelines? I want to have a dental kit, an eye kit, and I need to have a stethoscope, and I got to have all the things. And maybe is the answer. And then the other answer is maybe not. And I think it really depends on who you're covering and where you are. Back to our very first slide, we want to think about those common injuries first. And again, many cases our athletic trainers will have these things, but I want to make sure I've got a way to check vital signs. You can think about, do you need a glucometer? Do you know you have athletes who are diabetic, who might be hypoglycemic or hyperglycemic? Again, if the athletic trainer has that equipment, maybe you don't need it. Do you want to carry a handheld ultrasound? I sometimes do. I don't always, right? Where are you going to be and what kind of pictures are you going to be taking? I do think an eye kit makes sense. You want to have some fluorescein strips, a way to get a blue light. You want to have a contact lens case and some artificial tears or saline solution because eye injuries are common. And that's an easy thing where we can do a quick evaluation there on the sideline or in the locker room to look for that corneal abrasion or other eye injury to decide, do they get to stay on the sideline or are we going to send them on? Things like wound care, right? Simple wound care, sure. Again, athletic trainers will often have the gauze and the band-aids and the bandages and some wound cleaning supplies. But you want to ask yourself, am I going to have suture materials? And I don't have a good answer for that. I think it depends on where you are, right? I've often said, if I'm at a youth sports event, like my kid's baseball game or basketball game, am I going to suture a kid on the sidelines? And the answer is I am not, right? I'm not going to suture a kid at the sideline of a youth sports event unless I've been specifically contracted to be there as the physician covering a tournament. I think that's generally something that could move on to urgent care if a kid needs sutures. At the high school level, again, we're still talking about minors, right? So you want to ask, do we have parental permission to do this? Do we need to do this laceration here? Or really would this be better served by going on to the urgent care and getting it done in a controlled setting? At the college, have I put in sutures on the sideline? I have. We have our training room that's very close. And so usually I'll sort of retire from the sideline to the training room to get this done in a slightly cleaner or more controlled setting. And certainly professional sports, we do this frequently. Hockey for sure. We have all our suture supplies right there in our doctor's office. But again, we've set that up with good overhead lighting, with the lidocaine we need for anesthesia. We've got all the suture supplies we need so that we can do them. And so again, the question of does suture material go in my bag? The answer is no, I don't fill up space in my bag with suture material because if I'm going to do sutures, I usually have those supplies in my training room. Or if we're not at a place where the training room is available to me, I'm going to send those folks on to the ER or to urgent care. When you want to think about your response to more serious conditions, right? Do you want to have IV supplies? Do you want to have airway supplies, medications? And again, more complex wound care stuff we just spoke about. IV supplies is a tricky one. Again, youth sports, high school sports, no, like that's just not what I'm going to do at a youth game. I think we've all seen in the setting of the recent IV fluid shortage that really we can do a lot of management of illness without IV fluids, and that this move to put an IV in everyone very quickly was probably a knee-jerk response and was not necessarily best practice medicine. And so again, I don't tend to carry IV supplies with me. When do I take IV supplies? If I'm traveling with a team for a period of time, for several days, let's say we're going overseas, I'm taking a team someplace where I'm worried about there being traveler's diarrhea, right? If I'm going someplace with a group that's going to have difficult accessing other medical care, I'll probably take some IV supplies in those cases. But again, that's not just routine to have it before game or after game. Airway supplies, I think, are tricky. I do tend to think we should have some OP or NP airways, right? I think I ask myself the question of, what do I need if I'm going to manage this airway by myself, right? And how long am I going to do that? Am I at a soccer game where there's no EMS, but they could be here within 7 minutes? How am I going to manage an airway for 7 minutes by myself, or with just me and an athletic trainer? And the answer there may be to have a back valve mask and an oral airway or some NP airways, right? Do I carry supraglottic airways? Am I carrying eye gels with me? Again, high school and college, I'm not, because who's going to help me with that airway, right? Once I've put in that airway, I'm sort of obligated to bagging this athlete. And you have to ask, what are the situations in which this is going to happen, right? In a cardiac arrest, my time and energy are probably better spent on high quality CPR and defibrillation until someone else can come and help with the airway. And short of being the NFL or NHL airway doc, I'm not carrying intubation equipment. And so that gets us ahead to things like medications. Am I carrying an RSI kit? I'll put the NHL in a different category for a moment, but for all these other things, I'm not. Because if somebody has an airway emergency, who's going to put in that IV? Who's going to push those medicines? Who's going to do the airway, right? The simple answer is that one clinician cannot do all three safely, right? So unless you have a paramedic team there and you've agreed who's going to draw up the meds, who's going to push the meds, who's going to do the airway, I think that having RSI medicines is just a waste of medicines. You're going to be carrying them around. And I don't know that we can safely administer them and do all parts of that rescue ourselves. So again, going back to this question of the high school game, right? Am I going to RSI and intubate a high school football player on the sideline? I'm not, right? Like, I've already made my decision that I'm going to have other ways to manage that airway that I think are BLS manners of airway management and are probably safer as a single rescuer. The data also shows that BLS airway management outside of the hospital is probably the best goal. Even in EMS systems in Europe, where physicians are riding along with the ambulances, they show no survival benefit to those advanced airways when placed by physicians in the pre-hospital setting, and that's usually because that airway is being placed at the expense of other care. I also caution, and I'll give a caveat here, I'm not an attorney, right? I'm not giving legal advice, but I think there is something to be said for the fact that if you carry equipment with you and then don't use it, someone could ask, if there's a bad outcome, why didn't you use that? Why didn't you use that equipment? And so I think it's sometimes better to not have it than to have it and not use it, right? So if you say, well, I have this RSI equipment, but I didn't use it because I didn't have anybody to help me place the IV, I don't know where that would put you in a medical legal standpoint. All right, so then packing your bag, right? I think this is an old version of the bag we carried in our airway team for the NHL. But remember, in the NHL and the NFL has a similar role, that airway and that resuscitation is really our primary goal, right? So when I'm packing that bag, I'm packing for sort of resuscitation first, right? So we have a bleeding kit that includes hemostatic gauze and a tourniquet, actually 2 tourniquets, scissors. We carry an EpiPen in our kit primarily because we have folks who are known to be anaphylactic in our group. We have a specific airway roll, an IV start kit. We carry a video laryngoscope with us. Our airway roll is kind of 9 ways to get an airway. Why? Because we're the ones who are supposed to get the airway in this case. So we have supraglottic airways. This is from a few years ago. We were carrying Kings and LMAs at that point. We've replaced them with eye gels. We have an end-tidal CO2. We've got regular endotracheal tubes that can be placed either with a direct laryngoscope or with a video laryngoscope. We have a cric kit. We have a bougie. I mean, you name it, we've got it here because we want to make sure we get that airway no matter what the situation is. The value here also is that we have two excellent paramedics who are there with us, and we have made an agreement that, again, we are carrying RSI medications and an IO, EasyIO kit. And we know that the first paramedic is going to be placing the IV. The second paramedic can double check our drug pull-ups. We'll pull up the drugs, and that one of us will place the airway. We've got sort of that NASCAR style approach to how we're doing this that is different from what would happen if I were even on the sidelines of a high level college or a pro team that doesn't have an airway specialist, right? So when I'm with the Capitals and when Landon's with the Capitals and we're doing this as the IV or as the airway specialist, we know that we have another primary care sports doctor and two paramedics who are there helping us in this resuscitation. So everybody has a role. I would carry none of this with me to a youth sport game. I would carry none of this with me to a high school team. And really, I don't care this for my college team either. I am a little bit spoiled by the fact that Georgetown University Athletics is their sports fields are about 600 yards from our ER. So there's really no circumstance under which I would do these things on the field at Georgetown. I'm going to get in the ambulance and go to the ER where we have all of our toys. I will put a shout out here for something the NHL has done, which I think is a fantastic thing, and I really wish more leagues would do. And we call this the red bag. The NHL put together this basic red bag probably almost 10 years ago. And the idea is that the same bag of rescue equipment is available at every facility. So as the home facility, we'll have one of these bags in the home locker room, one in the visiting locker room. We put a third one in our doctor's office at the arena. And that way, when the visiting team comes, they know that that emergency supply bag has the same stuff in Washington as it does in Edmonton, as it does in Vegas, right? The equipment is exactly the same. And when we go to the athletic trainer and physicians meetings every year, we actually do emergency action planning training out of the red bag. We actually call it the red bag training course. So the red bag has in it eye gels. It has a better suction than what you see here. It has wound care supplies. And they're laid out the same and the equipment is the same everywhere. So you can reach into the bag almost blindly and pull out what you need. And again, that's going to be the same in Carolina as it is in Tampa Bay, as it is in Chicago, right? So the bag training is really helpful. I think more teams and leagues should do this because I think it would help us when our team is working with your team to save the life of this athlete who's in front of us. When we think about emergency action plans, I think you can't talk about what goes into your bag without thinking about what goes into your virtual bag, which is kind of your brain full of tricks. I think we have to talk about emergency action plans. Know that when you say emergency action plan to an athletic trainer, they probably use the NATA definition, which is more of a map. Then most of what we think of as physicians were more like protocols. So the NATA emergency action plan might look like this. This is our plan for Capital One Arena. It defines who's where. It defines where the AEDs are. It defines where EMS is and what are our routes for egress, right? So the location of key equipment and how do we get out? That's usually posted with a list of the key phone numbers and the critical personnel that would need to be contacted in any emergency. Contrast that to this, and you don't even have to really look through this to know that this is very much like an ACLS algorithm, right? The World Athletics Race Emergency Medicine course, the Boston Marathon emergency action plan. This is the emergency cardiac care algorithm. And it really reads like an ACLS algorithm. You know, if then this is this present, yes, go this way. If this is present, no, go this way, and just takes you through the algorithm. And I think having a few of these for the key emergencies like cardiac arrest, like spine injury, like severe hemorrhage is very helpful. So everybody knows exactly how we're going to move through those steps. I think it's important to at least pause and think about mass casualty incidents, right? Which is simply put an incident in which the emergency resources are overwhelmed by the number and severity of casualties. If it's you and an athletic trainer on the sideline and you have a bleacher collapse, it may only be 4 or 5 severe injuries before you are overwhelmed when there are only 2 of you there, right? So it doesn't have to be hundreds of victims to be a mass casualty. It just has to be more victims than you're ready to manage. We know that when we're out in the world, this could include things like active shooters, like we saw at Mandalay Bay, not a sporting event, but still a large gathering. But remember that years ago at the Toronto Raptors NBA celebration, their victory parade, there was a shooting and 4 people were injured. Bombings, like the Boston bombing or like the one that happened just outside the arena during the Paris attacks, right? Paris playing Germany or France playing Germany in a friendly, and the bomb didn't get in. It was appropriately stopped outside, but still caused disruption to the game and a decision about how we manage the athletes and the people inside that arena. My personal nightmare is a stampede, or what we call a human crush event, which usually happens when people are either moving towards a perceived reward or away from a perceived threat. In sporting events, this often happens where they're oversold or where people are being kept out of certain areas and they end up crushing against a gate or crushing against a small door. Hundreds of people can die. And in soccer matches around the world, hundreds of people have died because of human crush events. So you need to think about how you keep yourself safe, how you keep your athletes safe, and then how we go back and provide care for the dozens of victims that may be behind. Most of you are probably too young to remember when the earthquake hit in the middle of the World Series in San Francisco. Some of you may have seen a much less serious earthquake that happened in the Southwest. A couple games were stopped in Vegas. It was actually the Washington Mystics playing Las Vegas Aces and actually stopped a game at halftime because of a small earthquake that hit in Las Vegas, and they weren't 100% sure that there was structural integrity of the building. So recognize that when things like earthquakes happen, we don't just have to worry about the safety of our athletes in the moment, but it may disrupt roads, our egress in and out, may affect water mains, hospitals, etc. Other weather events, right? I think lightning is the one that I think about most because it can certainly cause mass damage, but we need to think about high winds, high rains, may affect transport, may affect communication. And then in case of lightning in particular, it may change your mass casualty triage algorithm, where we actually go to the cardiac arrest victims first in lightning because they are salvageable, unlike in other trauma events. And then something we think about perhaps more in DC and big urban centers than other places, but chemical, biological, radiological, and nuclear. I just throw this out to say that many of our sporting events happen in places which are co-located with other potential soft targets. So many of our arenas are co-located with mass transit. Many of our major sporting events happen in major cities. In DC, we think about the fact that we have over 1,000 what we call First Amendment events, permitted First Amendment events. That means protests per year, which means that we're often disrupted and there are often threats that are surrounding us. So make sure you work with your security folks to know what the threats are and have a plan for what you do if you suspect a bad actor. Have your emergency action plan. For those of you who don't know, this is my younger sister, right? So every time I think I have a really cool job, I remember that my sister flies F-15s and I'm put back in my place. But in military aviation, they have what they call 0-0 decisions, which means the decisions they make is 0 knots and 0 altitude, or right here in a classroom, in a lecture setting, you make your decision about how you're going to manage that emergency. And then you do that, right? So I know that if I'm with the Wizards, right, my primary care is to the team. So if there's an event at the stadium, I'm going to get my team and get myself on the bus to care for the team and the staff. If I'm there with the Capitals, same arena, different night of the week, I know that they have a different primary care doctor, a different orthopedist, a whole healthcare team that is going to take care of the team and the staff. They get on the bus. I'm there as the emergency airway person. I'm going to stay with EMS. We're going to evacuate. We're going to come back and see how we can help in the arena, right? So different, same stadium, same event. I'm going to manage that differently because I've made that decision and I've communicated it to my team. Remember that if you are evacuating with your team, my sister says you want to run until running feels ridiculous, which means just get so far away from the event that you're no longer part of it. That's a little hard as emergency physicians to think about that. But when you're the team physician, remember that your first responsibility may be to your team and your health and safety of your athletes and the staff. And you're going to let the EMS team and the event medicine and the disaster preparedness team come in behind you. I think that there's a whole nother talk to be had here. In fact, there's sort of a talk I'll be giving at AMSSM this year. It's about when to load and go and when to stay and play. And again, that's going to depend on who you're taking care of, where your resources are, and what you have on site, right? So when are you going to run your code in place versus when are you going to run it and get to the hospital? I'm going to do that very differently if I'm at a remote race than I am if I'm at Georgetown and my hospital 600 yards away. So our usual load and go and stay and play decisions may be altered a little bit, but you ought to make that plan in advance so you're not having an argument over the injured athlete. And then I think that you just need to know what you're planning for. Know where your pharmacy resources are. Know where your radiology resources are. Know where your closest emergency department or urgent care is. Because remember, we're all used to practicing in ERs, but sometimes these are urgent care type injuries, lacerations, sprains, strains. We don't have to overstress the ERs. Know where your trauma center is, right? If you've got a neurosurgical emergency, are you going to the closest ER or are you going to the trauma center? That means also having good interactions with EMS. And if you're remote, knowing where you're going to land a helicopter if you need to really evac somebody to a higher level of care. And the bottom line is if you plan well and you prepare well, then you're going to perform well. So it's not just about what you actually pack in your bag, it's about what you've thought about in advance. Most of the residents and fellows who've rotated with me know that for most games, I bring an Nalgene bottle of water, right? I don't actually bring a big bag, a big kit full of stuff, because again, I'm lucky to be in an urban center. My athletic trainers have the basic stuff, and I feel like what's in my brain is probably what I bring best to the sidelines. So plan and prepare, and then you can show up with your car keys and a water bottle. And then I'd be happy to take any questions. I know I ran a little over because I do that.
Thank you so much, Dr. Hudson. I really enjoyed that talk, and you give really good perspective on the different situations that you might be in. Just have one question, and then we will transition to the next talk. So, what recommendations do you give to students or residents who may not have a great sports medicine infrastructure at their programs on how to get involved and get this exposure?
Well, that's an excellent question. And I will say definitely come to the panel at 3 o'clock if anybody can, because I think we'll talk about some of that. But I always tell people that I think you start with the low hanging fruit first. I think that if you can get involved with a race, it's low time commitment and you get to meet a lot of people in your area who are kind of sports med junkies. So if you don't have an EM sports person and you don't know who your people are, cover a 10K or a 10 miler and you're going to meet some. From there, you can get involved with things like pre-participation physicals. You're going to find the people who cover the high schools, and you can ask if you can tag along at some high school games. Same thing with the junior colleges. You'll find some access there. But I think that there's two ways to do this, and one is to start cold calling people, right? Call the high school and figure out who their doctor is or who their athletic trainer is. Call the college and do the same. But I think that places like races, and I'm maybe a little bit biased because I like race medicine, but races are an easy way to, on a Sunday morning for a couple of hours, really make some great contacts of people who will almost certainly be excited about having you join them in whatever their next adventure is.
All right. Thank you so much, Kori. Really great talk. And looking forward to seeing you on the panel in a couple hours.